Before we get into today's topic of discussing intellectual developmental disorder, we first have to briefly go over the definition of neurodevelopmental disorders. This is because neurodevelopmental disorders are actually a broader category that include intellectual disability, but also some of the other indications that we will be discussing later on, such as autism spectrum disorder, as well as ADHD. So, neurodevelopmental disorders are a group of conditions with onset in the developmental period. These disorders typically manifest early in development, often before the child enters school, and are characterized by developmental deficits that produce impairments of personal, social, academic, or occupational functioning. The range of developmental deficits is quite vast, as it varies from various specific limitations of learning or control of executive functionings to global impairments of social skills or intelligence. And although it does not occur every time, neurodevelopmental disorders frequently have comorbid diagnoses. For example, individuals that have autism spectrum disorder often have intellectual disability, and many children with attention deficit hyperactivity disorder also have a specific learning disorder. Okay, so let's talk about intellectual disability. So, intellectual developmental disorder is characterized by deficits in general mental abilities such as reasoning, being able to solve problems, planning, thinking abstractly, judgment, academic learning, and also learning from experience. The deficits result in impairments of adaptive functioning, such as the individual failing to meet standards of personal independence and social responsibility in one or more aspects of daily life. For example, this could include impairments in communication, social participation, academic or occupational functioning, and personal independence at home or in a community setting. With intellectual disability, there can also be global developmental delays. And as the name implies, global developmental delays are diagnosed when an individual fails to meet expected developmental milestones in several areas of intellectual functioning. The diagnosis is used for individuals who are unable to undergo assisted, systematic assessment of intellectual functioning, including children who are too young to participate in standardized testing periods. Okay, so that was a brief overview of intellectual developmental disorder. However, how does the DSM 5 define intellectual disability? Well, the diagnostic criteria of the DSM 5 explains that the following three criteria A, criteria B, and criteria C, must be met in order for an individual to get diagnosed with intellectual developmental disorder. So, what we're going to do is that we will first discuss criterion A, then we'll move to B, and then finally we'll discuss criterion C. And then after all three criteria are discussed, what we'll do is we'll apply them to see how they are represented in a more real world setting. So, criterion A explains that in order for an individual to receive a diagnosis of intellectual disability, they must have deficits in intellectual functioning, such as reasoning, problem solving, planning, thinking abstractly, judgment, academic learning, and also learning from experience. These deficits will need to be confirmed by both clinical assessment, which typically involves a medical history, as well as some behavioral assessments, and also an individualized standardized intelligence testing. Now, the main aspect of criterion A is the focus on intellectual functioning. So, again, this is going to involve an ability to reason, plan, think abstractly, learn from instructions and experiences, and also having practical understanding of the task or the situation that the individual is in. Other critical components include an individual's ability to comprehend and understand speech or words, working memory, or the ability to temporarily hold and manipulate a limited amount of information for a short period of time, perceptual reasoning, quantitative reasoning, abstract thoughts, and cognitive efficacy. Now, typically, intellectual functioning is measured with individually administered and psychometrically valid comprehensive tests of intelligence. Individuals with intellectual disability have scores of approximately 2 standard deviations or more below the population mean, which includes a margin of measurement error, which is generally about 5 points. So, For example, on a test with a standard deviation of 15 and a mean of 100, this involves a score between 65 to 75. Okay, so criterion A really focused on intellectual functioning or an individual's ability to operate cognitively and also manipulate and understand the information that they are receiving through all of their senses. Criterion B, on the other hand, is going to focus on adaptive functioning. So, criterion B explains that deficits in adaptive functioning result in failure to meet developmental and sociocultural standards for personal independence and social responsibility. Without ongoing support, the adaptive deficits limit functioning and one or more activities of daily life, such as communication, social participation, and independent living across multiple environments such as home, school, work, and community. Essentially, criterion B refers to how well a person meets community standards of personal independence and social responsibility and compares that data to others of similar age and sociocultural background. Adaptive functioning in criterion B involves adaptive reasoning in three domains: conceptual, social, and the practical domain. The conceptual or the academic domain involves competency in memory, language, reading, writing, math, acquisition of practical knowledge, problem solving, and judgment in novel or new situations, among many other factors. The social domain involves awareness of others' thoughts, feelings, and experiences. This can also include empathy, interpersonal communication skills, ability to make friends, and also judge a social situation. For the practical domain, this typically involves learning and self management across life settings, including personal care, job responsibilities, money management, such as savings, recreational activities, self management of behaviors, school, work, and management of taxes. As you can see and are probably imagining, adaptive functioning is a complex feature as it's influenced from various elements such as intellectual capacity, one's education, one's motivation, one's socialization, their personality features, their vocational opportunities, cultural experiences, and also any coexisting general medical conditions or other comorbid mental disorders. In a little bit, we'll actually come back to adaptive functioning to better define what the conceptual domain, social domain, and practical domain represent in a real world setting across a variety of severities. Okay, so to meet criterion B, at least one domain of adaptive functioning needs to be so sufficiently impaired that ongoing support is needed in order for the person to perform adequately in one or more life settings at school, work, home, or in the community. Now, for our last criteria C. Criteria C essentially explains that the onset of the intellectual and adaptive deficits need to occur during the individual's developmental period. In other words, these deficits in intellectual functioning or in adaptive functioning need to be present during childhood or adolescence. Now, in order to fully grasp this disorder from a diagnostic and clinical perspective, we must make sense of it in a real world setting. More specifically, the term adaptive functioning that you keep hearing needs to be illustrated practically across settings and severities. Intellectual developmental disorder has four specifiers that include mild, moderate, severe, and profound. We will be reviewing all four specifiers. However, before we do that, it's important to note that the various levels of severity are defined on the basis of functioning and not an IQ score. This is because adaptive functioning is what determines the level of support required for someone that has an intellectual disability. Moreover, IQ measures are less valid in the lower end of the IQ range. One last housekeeping item before we start to break down what adaptive functioning really means. In the DSM, adaptive functioning, as we mentioned, is broken down into the conceptual domain, the social domain, and then the practical domain. And the way in which the DSM goes about to explain these various perspectives and domains is by sectioning them off into mild severity, moderate, severe, and profound severity. So, how we're going to work through this process is that we will first discuss the conceptual domain from a mild severity perspective, then the social domain, again from the mild severity perspective, and then the practical domain, still in the mild severity. Once we move off, once we finish the mild severity, we'll move on to moderate, severe, and profound, and we'll continue that rhythm of covering the conceptual domain, the social domain, and then the practical domain. The only thing that will change is, of course, the different severities that we will be walking through. So again, we'll start off with mild, move to moderate, move to severe, and again discuss those three domains, and then move to profound, and again discuss those three domains. Starting off with mild severity from a conceptual domain perspective. In this domain, preschool children may have no obvious conceptual differences. However, this is different for school-age children. For school-age children and adults, there are difficulties in learning academic skills involving reading, writing, arithmetic, time, or money, with support needed in one or more areas to meet age-related expectations. For adults, abstract thinking, executive functioning, such as planning ahead, setting a strategy, setting priorities, cognitive flexibility, and also short-term memory are impaired. Moving on to social domain, even with a mild severity, these individuals may have difficulties in accurately perceiving their peers' social cues. Additionally, communication, conversation, and language are more concrete or immature than what's expected for their age, and there also may be difficulties in regulating emotions and behaviors in an age appropriate fashion. The individual is also at risk of being manipulated in social situations and also with other individuals. And there seems to be a limited understanding of risks involved in social situations. When we're looking at the real world practical domain, since we are still in the mild severity levels, the individual may function relatively age appropriately with personal care, but may need some support with complex daily living tasks in comparison to their peers. In adulthood, support typically accompanies grocery shopping, transportation, home and child care, organization, nutritious food preparation, and money management. Recreational skills resemble those of their peers, although judgment related to well being and organization around recreational activities require support. In adulthood, competitive employment is often seen in jobs that do not emphasize conceptual skills. This means that individuals generally need support to make healthcare decisions and also legal decisions, and to learn to perform a skill competently. Support is also typically needed to raise a family. Now, moving into moderate severity, this is where we start to see a lot of those deficits start to increase quite significantly, especially when looking at school age children. So, with the conceptual domain under moderate severity, the individual's conceptual skills are largely behind those of their peers. For preschoolers, language and pre academic skills develop slowly. For school age children, progress in reading, writing, arithmetic, and understanding of time and money also occurs slowly across the school years and is markedly limited compared with that of their peers. For adults, academic skill development is typically at an elementary level, and support is required for all use of academic skill and work and personal life. Ongoing assistance on a daily basis is needed to complete conceptual tasks of day to day life, and others may take over these responsibilities fully for the individual. From a social domain perspective, the individual shows marked differences in social and communicative behaviors across developmental periods. Spoken language is typically a primary tool for social communication, but is much less complex than that of their peers. Capacity for relationships is tied to family and friends, and the individual may have successful friendships across life and sometimes even romantic relations in adulthood. However, individuals may not perceive or interpret social cues accurately. Social judgment and decision making abilities are also limited. Friendships with typically developing peers are often affected by communication or social limitations. Significant social and communicative support is needed in work settings for success. Now, thinking about the practical domain at a moderate severity, the individual can care for personal needs involving feeding, dressing, elimination, and hygiene as an adult, although an extended period of teaching and time is needed in practice for the individual to become independent in these areas, and reminders may be needed. Similarly, participation in all household tasks can be achieved by adulthood, although an extended period of teaching is needed, and ongoing support will typically occur for adult level performance. Independent employment and jobs that require limited conceptual and communication skills can be achieved. Considerable support from coworkers, supervisors, and others will be needed to manage social expectations, job complexities, ancillary responsibilities such as scheduling, transportation, health benefits, and money management. A variety of recreational skills can be developed and typically require additional support and learning opportunities over an extended period of time. Maladaptive behaviors, interestingly enough, can be present in a significant minority and cause social problems. We will touch upon that a little bit later. Increasing the severity again, when looking at severe levels, attainment of conceptual skills is overall very, very limited. The individual generally has little understanding of written language or of concepts, including numbers, quantity, time, money, and there will likely be a caretaker providing extensive support for problem solving throughout the individual's life. For social domains, spoken language is quite limited in terms of vocabulary and grammar when we reach these severe levels. Speech may also be just strictly from the words or phrases and may be supplemented throughout augmented means. Um, Speech and communication typically at this severity are focused on the here and now within everyday events, and language is used for social communication more than for explanation. Individuals understand simple speech, and nonverbal communication can also be developed. In the practical domain, the individual requires support for all activities of daily living, which includes meals, dressing, bathing, and elimination. The individual requires supervision at all time, and the person cannot make responsible decisions regarding well being of self or others. In adulthood, participation in tasks at home, recreational activities, and work all really require ongoing support and assistance. Now, moving on to the last and most severe level, the profound category. Profound limitations in conceptual skills generally involve the individual interacting strictly with the physical world and not utilizing symbolic or higher level processes. The individual may use objects in a goal directed fashion for self care, work, and recreational activities. Certain visuospatial skills, such as matching and sorting based on physical characteristics, may be developed. However, co occurring motor and sensory impairments may prevent functional use of those objects. In terms of the social domain, the individual has very limited understanding of symbolic communication in speech or in gestures. He or she may understand some simple instructions or gestures, and the individual expresses his or her own desires and emotions largely through nonverbal and non symbolic communication. The person can enjoy relationships with well known family members, caretakers, and familiar others, and initiate and respond to social interactions through gestures and emotional cues. For the practical domain, at a profound level, the individual is dependent on others for all aspects of daily physical care, health, and safety, although the person may be able to participate in some of these activities as well with practice. Individuals without severe physical impairments may assist in some daily work tasks at home, for example, carrying dishes to the table. Simple actions with objects may be the basis of participation in some vocational activities with high levels of ongoing support. Recreational activities may involve listening to music, watching movies, going out for walks, or participating in water activities, all with the support of others. Co occurring physical and sensory impairments are frequent barriers to participation in home recreation and vocational activities. Now, I know that was a lot of information to absorb, but I hope it illustrated how complex and non straightforward at times this indication can be when we apply it to real world settings across various severities. So, now that we have a better understanding of all of these complex behaviors and traits, what about the prevalence and course of intellectual disability? Well, intellectual disability has an overall general population prevalence of approximately 1%. Onset of intellectual disability is, as we mentioned, in the developmental period, so that's childhood and adolescence. And the main characteristic features and onsets depend on the etiology and severity of brain dysfunction. Delayed motor abilities, language, and social milestones may be identifiable within the first 2 years of life among those with more severe intellectual disabilities, while mild levels may not be identifiable until school age, when difficulties with academic, arithmetic, vocabulary learning become more apparent. So, if the main characteristic feature and onset of intellectual disability depends on the etiology and severity of the brain deficit, what are the etiological factors that we have to look at? Well, one of the places where we can start is through the individual's genetics, physiology, and sometimes even the individual's sex. So, prenatal etiologies include genetic syndromes, errors of metabolism, brain malformations, maternal diseases, which can include placental diseases, and environmental influences such as alcohol consumption, drugs, or toxins. Perinatal causes include a variety of labor and delivery related events leading to neonatal encephalopathy. Postnatal causes include hypoxic ischemic injury, which is brain damage caused by lack of oxygen and blood flow to the brain, traumatic brain injuries, infections, demyelinating disorders, seizure disorders, severe and chronic social deprivation, toxic metabolic syndromes, and intoxication of lead or mercury. When thinking about sex differences, overall, males are more likely than females to be diagnosed with both mild and severe forms of intellectual disability. However, gender ratios vary wildly in reported studies. Sex linked genetic factors and male vulnerability to brain insults may account for some of the gender differences, however, not all. Essentially, what this means is that males seem to have a higher chance of getting hit in the head and sustaining some sort of brain injury. And this can be either through recreational activities, work activities, or accidents. Now, if we're imagining that we are completing a comprehensive evaluation on a hypothetical patient, so far we've been able to identify the prevalence, we've been able to discuss and get a better understanding of what the course may or may not look like. We've discussed genetic factors, physiological factors, and also sex differences. One of the things that we are missing and need to take into consideration is diagnostic markers. So, in order to complete a comprehensive evaluation, typically this is going to include an assessment of intellectual capacity and adaptive functioning, as well as identification of genetic and non genetic evaluations for associated medical conditions such as cerebral palsy or seizure disorders. And also, we need to evaluate for any co occurring mental, emotional, and behavioral disorders. Components of this evaluation may include basic pre and perinatal medical history, a three-generational family pedigree, physical examinations, genetic evaluations, metabolic screenings, and also neuroimaging assessments. Now, the last portion that we will need in order to complete a very comprehensive case conceptualization on someone that may have intellectual disability is taking a look at any potential comorbidity. Now, in psychiatry, comorbidity and co occurring disorders tend to be the rule rather than the exception. Very rarely will you see or come across a patient that has a very clean, so to speak, medical history where there is only one diagnosis or one specific indication that explains everything. And so, what I'm trying to allude to is that co occurring mental, neurodevelopmental, medical, and physical conditions are frequent in individuals that have an intellectual disability. The rates vary, but the rate for some of these conditions can be 3 to 4 times higher than the general population. The prognosis and outcome of co occurring diagnoses may be influenced by the presence of intellectual disability. Assessment procedures may require modifications because of associated disorders, including communication disorders, autism spectrum disorders, motor disorders, sensory disorders, or other disorders. Knowledgeable informants are essential for identifying symptoms such as irritability, mood dysregulation, aggression, eating problems, sleeping problems, and for assessing adaptive functioning in various community settings. Typically, the most common co occurring mental and neurodevelopmental disorders are ADHD, depressive and bipolar disorders, anxiety disorders, autism spectrum disorders, stereotypic movement disorders, impulse control disorders, and cognitive disorders. So it goes without saying that co occurring diagnoses tend to be the rule rather than the exception for intellectual disabilities. What about brain anatomy? Well, when looking at brain anatomy as it relates to intellectual disability, we see a wide array of limitations stretching from reductions in size to reductions in just overall brain activity. These limitations can be formed from a variety of factors, which include brain injuries, perinatal incidents, prenatal brain insults, and genetic as well as chromosomal abnormalities. And just to clarify, perinatal incidence means incidents that occur around the time of birth of the child, and prenatal incidence means that the insult or the injury occurred before the birth of the child. Overall, when looking at intellectual disabilities from a brain structure perspective, we see a reduced brain volume, abnormal or low cortical thickness. So, in other words, a reduction in the thickness of the outermost layer of the brain or of the cerebral cortex, reduced corpus callosum size and neuronal loss, typically as a result from fetal alcohol disorder, limited myelination of neurons, usually due to maternal malnutrition, reduced size and activity of the hippocampus due to hypoxia. And this is actually extremely important because the hippocampus's role is in converting short term memories into long term memories, as well as forming new episodic memories, semantic memories, and also spatial memories. We also see a reduced size of the basal ganglia due to hypoxia. And again, very relevant, as the basal ganglia is a structure made up of the striatum, the caudate, the globus pallidus, and the putamen, and is crucial for voluntary motor movements. We also see limited activity in the prefrontal cortex, which can cause reduction in being able to perform executive functioning behaviors such as goal setting, planning, strategizing, etc. And we also see reduced activity of the NMDA receptor, which is the N-methyl D aspartate receptor. And this receptor is very important for learning as well as memory consolidation. Interestingly, we also see abnormal dendritic spine development, which these dendritic spines are crucial for neuroplasticity, learning, and memory. And these small dendritic spines are essentially these mushroom shaped spikes on the dendrites that are crucial for receiving information or for receiving synaptic input. Okay, so we've been talking a lot about the psychological and physiological factors that make up intellectual disability, but what about treatment modalities? Well, there is no cure for intellectual disability. There are interventions and treatments that are used to help the individual gain a more positive prognosis and quality of life. These various modalities can be summarized through developmental therapy, speech and language therapy to work on communication and also some nonverbal communication, occupational therapy focused on dressing, hygiene, eating, and just fine motor skills, physical therapy for motor delays if they're present, parent coaching and home based supportive developmental stimulation therapies, special education and individualized learning focused on academic achievements, self care, social skills, and vocational development, behavioral therapies for day to day functioning, communication skills, and mitigating self injurious or aggressive behaviors. Overall, early intervention in any and all of these domains will be helpful. Although these modalities are not necessarily cures for intellectual disability, they do build skills that the individual would otherwise struggle to learn on their own, thus giving the person a higher quality of life. With that, I hope you have enjoyed this brief but deep overview of intellectual developmental disorder. Intellectual disability is a complex disorder that affects the individual through various settings of their life, from school, work, and also social or personal relationships. The severity of these symptoms are also quite volatile because you can have an individual that may be strong in the social domain with making the right decisions, communicating verbally, non verbally, being able to read situations pretty well, but at the same time is having difficulties in the conceptual domain that involves more of that school setting where you have to think more abstractly or at a higher complexity. Of course, arithmetic learning, learning math, learning time, learning new words through vocabulary, etc. So, because there are so many elements that are involved in understanding intellectual disability, if there are any particular topics, etiological factors, or diagnostic elements that you would like to revisit at a deeper level, please be sure to comment it down below. If this episode captured your interests and you want to further support the channel at no cost, please consider giving the episode a like or share it with a friend.